Hey, Dr. Bhargava.
Jamie, how are you?
I'm doing well. I'm excited to finally be back here doing one of these Facebooks with you.
It has been a long time. And you know what? One big thing I want to reflect on today is this is April. We looked at our first quarter. What an unbelievable quarter. We had so many good things happening inside and outside and patient experiences. The education thing was amazing. What you guys did with your education program, several hundred visits, got the ADA certification. What else? The portal. We have now 2,000 people on the portal. That have joined us. So much happening. So many new research studies coming. Weekly insulin. So I think in this fight against diabetes, it feels like a good quarter. We
It
made it.
is.
Yeah,
I would completely agree with you. And as you guys, I see we've got a couple of people streaming on. As you join us, say hello. Let us know where you're viewing from. We always want to hear from you. But I cannot, I mean, the work that we put on for these diabetes education classes, it was a huge team effort, but it's been phenomenal. And I really feel like we've put together a strong program and patients are responding to it. Connie, welcome. Thanks for joining. So today, Dr. Bhargava, I think we're talking about one of our favorite topics. I'm going to put up a picture of what the topic kind of feels like if you want to take it away.
absolutely. So here's the thing. This is fun. When you do it for 30 seconds, you pay $30. You do it for 30 seconds. It's fun. But I don't want to do it all my life, every day, the ups and downs. So my patients with diabetes struggle with the ups and downs of diabetes. And my life would be so much better. And more importantly, my patient life would be so much better if we could just stop this, right? Stop this roller coaster, the ups and downs. And this is what today is about. We want to manage our sugars, but we want to avoid these ups and downs. So really, that's what this is about today. If you are having trouble with low sugars or high sugars, in the next 20 minutes, 30 minutes, you'll get a lot of input and tips that you can use to avoid this and how to manage them much better. If you know of friends or family who are struggling with this, let them know this is going on. Let them join. And as a reminder, this will be available after the event also. And if you have questions or comments, we will answer them as well. Well, I am Dr. Bhargava, Dr. B, very interested, engaged in diabetes since 1994, whatever year of number that is. I was 2 years old then. So, but doing everything in diabetes we can. And it's just a pleasure to be here today and talk about the ups and downs and reintroducing Jamie back, our rock star, our backbone, pharmacist, extremely passionate about diabetes. And together, we and our team is making a difference every day in diabetes. So, the key things today, Jamie, what are we learning today?
We are learning common reasons for low blood sugars, steps to prevent them, and then how do we actually treat them. And one of the things that I think that you and I are both passionate about are making people who have diabetes lives better. And actually, lows lead to highs. So many people go low and then rebound high on their sugars. So if we can prevent and take care of those lows, oftentimes we actually get your A1C down better and you feel better. Because if you've ever had that low, it really wipes you out. So let us know. So Suba, Kathy, Connie, I know you guys will
Yeah.
respond to me. How do you feel after you have a low, and how long does it take you to kind of get back to normal? The next thing that I have for you guys as well is an additional poll. So as I bring that up, let us know how you're impacted by lows. And Leah's asking, is anyone else having issues with buffering? If you guys are, please let us know. We want to make sure that it's not on our end at all.
And Jamie, are you showing us
Not,
showing slides?
yeah, not yet.
I see. So it's going a little bit slower, it seems.
Yeah.
I'm going to check our internet speed, and I might have to join in your room to at least bring one
Slow
of
it
them
down. Yeah.
down, if that happens. Keep
And
providing us
so,
feedback, team. Yeah.
yeah, Kathy is saying she's very wiped out by lows. and it takes a bit to recover. I think that's common. Suba, you're saying I do get low but bounce back quickly by eating a cracker or a piece of dry fruit. So good. Now let us know. It sounds like you guys are already answering. How satisfied are you with the fluctuations in your sugars? And again, Edgar, thank you for giving us that feedback that we're very slow. So Dr. Bhargava, if you want to join me, you can. Just to see if it's on our side. But it looks like some of you guys are satisfied and aren't having any problems with your lows. And it looks like some are somewhat satisfied as well. So we're going to be really talking through different ways that you can try to prevent those lows. And again, if we prevent those lows, we're going to hopefully prevent the highs that happen after that rebound. Welcome, Dr. B.
All right. Now you can see for the first time how much taller she is than me. I always look up to her. Okay.
So, and Connie's saying she's not satisfied either with the care or the fluctuations that she's having. And she's really trying to rely on the A1C, but it looks like she's gained some weight and when I do test sugars, they are high. So looks like you're having some things that we can hopefully talk and work through.
Well, let's take a moment to just talk about A1C versus sugars, right? So what if your A1C is good, it's 6.5, but then you are doing this, right? Is that good? No, that's not good either. So as we look at the blood sugars, they tell us a story of their own. And we want to talk about a concept today, what's called time in range in a minute. So Connie, there would be times you could have an A1C that looks good, but your sugars are fluctuating up and down. There are times your A1C is high and then you're not satisfied with your high sugars. And we'll talk a little bit about high sugars as well in a minute.
My favorite story that you tell to talk about A1C versus time in range is your river story. Do you want to tell that?
Well, so here's the story about a mathematician who was a very good mathematician. He did not know how to swim. He came across a river and he knew the river was 4 feet deep in an average and he was 5 feet, so it was going to be fine. And he tried to cross the river and he was never found. So the story is that averages don't tell you everything. A1C is an average of your last 90 days. It tells us very good stuff, but not everything. We still need to know what's happening at the bottom of that river, right? Ups and downs. So yeah.
So that brings us to the next slide, which is trying to figure out what are actual good blood sugars that our patients should be looking for. So blood sugar range is defined by the ADA, and this is the one that most patients are going to follow on diabetes. They say in the morning or before a meal, it's recommended to be 80 to 130. After a meal, about 2 hours after you eat, anything less than 180. The endocrinology guidelines, which is the Dr. Bhargava's association, they've got slightly tighter control with that 180 to 110 before meals and less than 140 after a meal. Dr. B, I like your rule of thumb.
So I like simplicity, right? Different numbers, and so many patients ask me all the time the numbers. So I kind of go with this idea that think about 80 to 120 as a good number for before meals and fasting, 80 to 120. And then think about another 40 on top of that for after meals. So like 160. As you'll find, this falls in the average of our two main associations. So 80 plus 40 plus 40. That's how I think about it. And I want to point out on the right side of the screen, the colors. As you will see, if any of you are on sensors, even meters, and you do reports, this is a standard thing we do now. And it's great. Its colors work so well. The stoplights work all the time. Hey, red, yellow, green. I know what that means. So in the diabetes world, the green means you are in range. And typically that range is determined between 70 and 180. A lot of you doctors should be talking about time in range. So 70 to 180 is the time in range in general for the day. Above 180 is high, below 70 is low. So think about that as well.
And Connie's asking a great question, because although these are the standards that we say for
Right.
the general population, we really do have to individualize it to you based on disease states, based on age, based on ability to move around. So what's your recommendation for older adults?
Yeah, great question. I'll answer it two ways. As we get older, we relax our targets. So when we think of the A1C, that average number, I like to say, that, again, I simplify as much as possible. 7 is 70, and then 0.1 for every year after that. So I'm okay with the 7.5 in a 75-year-old. Well, what that also means is that we should be able to relax the target by 10 or 20 points as you get older. I'm not going to worry about a 130 in the morning or a 138 if somebody is 78 years old and on an insulin. I'm going to say that's okay. So we do relax the targets for A1C, and similarly, it's okay to relax your targets for sugars as we get older. Not too much, like I'm not saying that above 200 is fine for any time. I'd still like to keep below 200 because that's when you start getting symptoms.
So I'm going to bring up Suba's comment about Freestyle Libre. He has this monitoring system, and he's been able to watch his lows to see that they come back. And I think that's the benefit of one of these sensors. I was actually talking with a patient yesterday who is on the Libre,
Yeah.
and he loved it because when he would scan, it would tell him whether he was in the green, the orange, or the
Yeah,
red zone. And
right.
he goes, I know if I'm green, I'm good. And
Right.
he loved that visual cue that this has.
Well, two things I'll say about sensors. It's something you guys want to think about for sure. So I'm glad you have a sensor. Many people who are on insulin, it's a great idea. And first, a blood sugar is a picture, a CGM or a sensor is a video. It tells you up and down, where are you going? Where have you been? Great thing. Second, well, of course, you don't have to poke yourself. Third, it's really a behavioral tool, actually. If you were good, it will tell you. If you're not so good, it will tell you. So think about getting a sensor. And when you get to sensor, the numbers kind of remain the same. But then a new thing gets added is we want your sugars to be in time and range. This is the association guideline too, 70% of the time. So your green should be about 70%.
And Sue was asking, are there specific recommendations based on the length of time that you have diabetes and maybe some of the medicines that you're on? So in this case, on insulin or something that can cause a low.
Yeah, so everything we do in life is risk benefit, right? We buy a car, risk benefit, there's benefit, there's cost. So everything. Similarly, in diabetes, when we are trying to shoot for good control, we say, what's the risk, what's the benefit? So now you have diabetes for a long time and you're on insulin, the risk is low sugar reactions. And that makes us back off. So somebody had diabetes for 46 years and on insulin, 7 or even 7.5 for A1C would be good. I would be satisfied with a 60% time in range as opposed to 70. I would rather see a little bit high, and that's okay.
Yeah, 0 lows
Yeah.
with the older population. That's what we're shooting for. So we want to review just a few things that can cause high sugars, and then we're going to really focus on low sugars and how to prevent them. So common reasons for high sugars.
Well, let's ask them.
Yeah.
All right, so you guys type in, if you saw 200, what was the reason? Just type in things that have led to high sugars for you. Because again, we'll talk a little bit about ups and then we'll talk about downs in a minute. So please tell us what has led to high sugars in your case. But Jamie, you go ahead.
For me, I think we came up with the S's is what it was. So simple sugars. So a high carb meal or desserts that are higher in some of those simple sugars and candy. Skipping meds, being sick, and then stress and steroids. And I say steroids as a medicine that can cause increased blood sugars. Kathy says higher fat meals too. What do you say about that, Dr. Bhargava?
Yeah, so I think high fat meals can do it, but they do it in a longer fashion. So your carbohydrates are those and 2, 3, 4 hours peaks and down. Proteins a little bit longer, up to 5, 6 hours. Your fats really get you high for 8, 10 hours. So let's say you have pizza, which is a mix of all these things, and you will have these sugars high for a while. So fat will do it too.
And Leah said pizza. Pizza is one of the big ones that we see. That's that high fat, high carb meal.
So, but you should try pizza and see what your CGM does. No, I'm not recommending pizza for diet. I'm just saying CGMs can really show you what it does. So no, I love this. So what you said was simple sugars, and in that, the juices, the rice and pasta, skipping medicine. So your diabetes meds, you do not want to skip meds for your diabetes, right? Take them regularly, unless you have a reason like low sugars or something, stress. I think this is what people don't realize is high stress will get all these other hormones up in the body, the cortisol, catecholamine, then they raise sugar. Being sick, your body needs more calories. All those other hormones are kicking in. And what was the fifth one? Steroids. A medication.
Yep.
So steroids and other medications. So be mindful of those things. So Jimmy, what should they do? So if they got their sugar high, what do you recommend?
It depends on what medicines you're on. If you're on an insulin and you know how to bring down a sugar based on a specific calculation called a correction factor, there is a safe way to bring it down with that insulin. It requires instruction from your diabetes educator or a doctor, because insulin is extremely specific and personalized. So one patient responds to it differently than another. You can also increase hydration and just move around.
Yes. So I have W's for that, walking in water.
Yep.
We do these hyperglycemia challenge in our back office. We're testing new sensors and so forth all the time. So when they're high, I say walk and drink water, because that flushes things out. And then, of course, medications. And look at the cause, those 5 S's. What can you do about those? And then learning from the previous time. Okay, when I do this, my sugar going 200. Well, I'll do less of that thing. So those are some of the things you want to do for high sugars.
Now, let's talk about lows. So a low blood sugar is defined by a blood sugar less than 70. If you do have a low blood sugar, you may start to be symptomatic. So some of the major things: dizzy, confused, heart racing, sweaty. There's more. If you've got a specific one that is specific to you, let us know what it is. How about you, Dr. Bhargava? Do you have other ones?
When I get low, I'm just shaky. So I don't have diabetes, but like this morning, 2 amazing meetings, and I was so excited at the shaking, so I had to eat some. So yeah, shaky, sweaty, hungry, tired. Now, these are what we call the symptoms because of the catecholamine and stuff. But if you have a lower sugar, so we think of sugars in 3 categories, and maybe Jamie has a slide on the categories. But in general, less than 70 is called low sugar. You get less than 54, we say, hey, that's a little bit more scary and could be harmful. So that is a little bit more. And then the severe one, which is like when you need help, right? So you do not want to have low sugars, especially less than 54 or where you need help. That's the time you need to let your doctor know that this happened. But that's what I would say. I think there's a comment from Leah.
It says, I've been on low carb for several months now. Blood sugars have decreased, but A1C hasn't come down like I hoped it would. And for me, Leah, as I'm looking and reading that comment, I think that tells us a blood sugar is going to be 1 point at a time, whereas an A1C is your average over 3 months. So getting a sensor to see what's happening in between may give you more insight as to what's happening in between the meals when you're not specifically checking and poking your finger. Any other thoughts on that one?
No, I think you made good lifestyle changes. You do it slowly, and over time it will show up. So a low carb diet many times will lead to a little bit of weight loss, then more insulin sensitivity, and it may be a matter of time also.
Do electrolytes affect sugars?
So the question, no, if I consume electrolytes, typically not. There's a relationship. When your sugars are high, your electrolytes definitely get affected, your sodium, potassium. But if you're talking about, if I had something with electrolytes, like a
Gatorade or a Powerade,
without any carbs in it, it should not.
Yeah. So let's review some of those common things that can cause a low blood sugar. We've told you what it is. On this slide are the top 4 reasons. I would say lack of food, too much medicine, too much exercise, and alcohol. If we're not going to spend too much time on the alcohol, we did an entire Facebook Live on this earlier this month, so go check that one out. But these are the most common things where you're not getting enough of the sugars in or taking too much of the other things that lower your sugar. So how do we prevent that from happening? I'll let you, as I manage the slides and getting them down, take a start.
So again, knowing the cause is the most important thing. When you have diabetes, it's not that every person with diabetes will get a low sugar reaction. It typically, generally, almost happens in people who are on insulin or these medicines called sulfonylureas or meglitinides. Sulfonylureas are the medicine that start with a G and end with an E. Glipizide, glyburide, glimepiride, the G and E medicine. So those are the ones if you are on or insulin. So some of those causes may not be relevant to somebody who's on other medications. On these, it's more important. So I actually, first thing I do is I try to avoid those medications. Yeah. I do not want my patients to have lows and highs. So in general, if I can avoid insulin, and in general, if I can avoid G2E medicine, glipizide, glyburide, I do that. So that covers kind of that medication aspect of thing. Being on the medications, if possible, I do not want anyone to stop any of the medicine they're on. They just need to talk to the doctor. But if you're on medicine that bring you down, but don't cause a low, that's the way to go, right? So being on those medications is one of the, as a clinician, a doctor, that's what I would do for you.
And we've got a saying here where we call those the fabulous four. There's many of them, but we have those preferred. And if you are on one of those medicines that cause a low, it's really important not to skip a meal or go too long without eating, because the glipizides, the glyburides, they make your body secrete more insulin and regardless of whether you're eating or not. And so if you go too long, you're going to go low. And it's the same thing with insulins, especially if you're on mealtime insulin. The timing of that insulin is crucial. Or if you give yourself an injection and forget to eat, that's really a risk factor for going low. Or if you only eat half the meal because you weren't as hungry and you took your standard dose, again, that mismatch is going to potentially cause a low for you. So working with your diabetes educator or doctor to figure out in those situations, what do I do to prevent them? It's really prevention. The more we can avoid the lows, the more we can get you guys to feel better. Can you repeat your little rhyme again?
I didn't know I was singing today. Was I? No.
The rhyme. Okay, I'm going to have to think back to which rhyme it was.
There's one for the S. There's one for
the W's, the water, and
walking.
Yeah.
Leah, sorry this is happening today. We'll have to look at our bandwidth and do something about it. But if you have not answered, please type it again.
And we'll get it. We'll get it. So my next question for you guys is, how many of you have a fire extinguisher at home?
What are you talking about? Fire extinguisher? Why are you talking about fire extinguisher?
Right. What if you have a
but
fire?
I'm curious, how many of you do have fire extinguisher at home? Just type in yes and no. Leah has a fire extinguisher. Good.
Yeah.
I have one at home. Jamie, do you have one?
Not in this house.
Oh my gosh.
I had one in my first house. I don't have one in this house.
Kathy doesn't. Leah does. Connie, yes.
And I do have a CO2 monitor.
Yes. All right. So why are we talking about this suddenly? Well, here's the thing. A hypoglycemia to me is like a fire. It could get out of control, right? You go below 70, then below 54. So you need fire extinguisher. And in case of hypoglycemia, your fire extinguisher is the glucagon. So the next question I will have is, especially if you're taking insulin, do you have glucagon at home? And then Jamie will describe, there has been such an amazing evolution of glucagon over the last 5 years that it's really worthy of thinking about it. And before you begin, Jamie, I'll tell you one thing, guys. Some of my patients say, hey, I had one, it expired and I had to throw it. And so why get another one? I said, the best use of a fire extinguisher is the one that's never used. Glucagon, the same. It's a fire extinguisher. It gives you that safety for 2 years, right? And then, yes, if you have to give a new one, great. You did not have a low sugar. You didn't pass out with a low sugar. So just think about this. This would be one of the key things that I would say today is think about making sure you have it, especially if you are taking insulin. So
And
Jamie, go ahead.
and I think the delivery of glucagon when it first came out, really, it's hard. They did an experiment and they actually showed how many people could correctly give glucagon with some training, and it was 30%. This is the old style. You get a vial that has some powder in it, and then you get some solution in here, and you're having to inject it in here, mix it, pull it out, and then inject it.
So I'm passed out, and Jamie's doing this, and I said, Jamie, when are you going to give me the glucagon?
Yeah. And it's just takes over 5 minutes. It's already a panic situation.
Right.
And I think that has led to so many people not using it and scared to use it. And patients would honestly not feel the greatest if they did have it used. They've revolutionized, not the drug, they've revolutionized the delivery of it. And so now they have these
make the slide go
auto
down so they can see it
injectors.
better.
Yeah, now they
This
have
would be-
these auto injectors, and it's simply take the red cap off,
I'm still waiting, Jamie.
make the yellow go away, and 2 clicks. 1 click when it starts, 1 click when it stops, and
Wow.
it's done. Over 98% of patients without training or caregivers can do that.
What is this one called?
This one is Gvoke.
Gvoke.
Yes.
Cool.
Gvoke was the first to the market for this auto injector. Zyalog is just a little bit different. It's a little faster than glucagon, but it works the same way. And so it's the same thing where it has that auto injector. The other one that I want to show you, just in case you're somebody that doesn't like injections or have somebody that's taking care of you that's scared of injections, is Baqsimi. And it looks like Kathy has Baqsimi, and she has it and says it's so easy. It's a nasal spray, and it actually goes in your nasal passageway, and you push it just like this all the way up, and that's how you deliver it.
That's it.
That's it. Patient doesn't have to breathe in. It's just this passive absorption around the nasal passage area. The only difference, sometimes a little bit of burning in that area if you're having to give it. But if you're less than 50 and you're starting to get disoriented, that's when your caregiver can absolutely reach out and start to give some of these. And you should get a full response with a blood sugar going up by 20 to 30 points in by 15 to 30 minutes. It depends on which one, but that's about the time frame.
And when you said if you are less than 50,
Yes.
you were talking about the sugar.
The
not
sugar,
age.
not the age.
I just wanted to clarify. It's for all people of all ages. It's just when you said if you're less than 50, and I said, I am almost less than 50. So, all right. Subha has a comment. Great suggestion to have glucagon. I never thought about it. I only keep sugar tablets. Yeah, I think sugar tablets. So here's another thing. Thank you for pointing that out, Subha. The sugar tablets, I'm a big fan of. So how to treat low sugars? Maybe we skip that part. Let's talk about that. 15 grams of carbohydrates is typical. What does that mean? Well, most people will go to the fridge with shaking hands and pour juice and drink it. Well, a cup of juice. And they will not stop at 1 cup of juice. Most of my patients, and myself included, will not stop at 1 cup. So I'll have 2 cups. Now, 2 cups of juice have 60 grams of carbs, not 15. So I'd say, that's
Juice.
Okay. So that's a glass. You have that glass at home?
This is a
I
glass of juice, and this is your serving size. So it's tiny. It's what I would feed my kids.
Yes. It's in kids' toys.
Yes.
That kind of glass. So 1 cup of milk, great idea. Glucose tablets, awesome. We did a training yesterday on exercise. And we talked about buy a bottle of glucose tablets. They'll have 50 of them. Take 3 to 4, depending on how big the tablet is. Put them in Ziploc bags and just spread them around. 1 in bathroom, 1 in bedroom, 1 in kitchen, 1 in car, 1 in purse, backpack. Just let them be. So Thank you for reminding us about that.
Yeah.
But yeah, please do get glucagon. You mentioned earlier you are on insulin, so definitely you got to have the fire extinguisher at home.
Yeah. The glucagon is for when you can't take in the sugar.
Right.
And one of those triggers that I tell our patients is when you're starting to be below 50 on the blood sugar.
Yes. Excellent.
You guys have asked so many good questions. We will continue to respond to them afterwards. So please keep the questions going in. Otherwise, final thoughts, Dr. Bhargava?
Well, I want to hear from them. Remember how
I know you
talk
do.
about takeaways. So the last question for you all, what's your number one thing that you want to remember 8 days later? What's that one thing if you want to type in? And in the meantime, I'll start summarizing. I think people with diabetes have the ups and the downs. Monitoring is the best way to know what's happening. CGMs or sensors is a great way of knowing ups and downs. You got to have a strategy for your ups and you got to have a strategy for lows. We wanted to focus more on lows today. So knowing the reasons why it's happening, avoiding those, knowing the symptoms, knowing how to treat with about the right amount of carbohydrates, the rule of 15 grams of carb, wait 15 minutes, repeat if still low. And then finally, having the fire extinguisher at home. So that's kind of the summary from my side.
Yeah.
But I'd like to hear comments from people.
And I think Kathy is saying, I think she means I love my new Dexcom. So
Excellent.
Great. For me, my summary, in addition to what you have already said, is glucagon has gotten better. Even the shelf life has gotten better. So a lot of these can sit at your house for 2+ years, whereas the original was about 6 months that it would last. So they have gotten longer. So having that around and accessible for whoever's helping you out, yes, have that be in your preparation of your low plan.
And lastly, just some feedback on the speed. Can you tell us if the speed still remained low in the later part? All right, Leah has a comment.
Leah's saying, thanks for offering these classes. Well, I appreciate that comment. So thank you so much, Leah. This is our passion, and so we just want to pass this knowledge on. We've got more information out there on our blogs and on our previous videos, so do watch them. We are having another session coming up in the end of May. I've got a guest speaker on. She's the director of Camp Hurt Go Hollow, which is a kids type 1, type 2 camp put on in the summer. Her name is Deb, and she's going to be joining us to talk about what it's like to be a caregiver for somebody with diabetes. So a little different perspective, but I've heard her talk on this before, and she's fantastic. Thank you, guys.
Thank you, everyone, for your comments. Let's keep working at our highs and lows. Let's keep working on making diabetes better. Let's change diabetes together.